Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and warm greetings to all of us. The Honorable, the Dean of the Faculty of Medicine, Universitas Andalas, represented today by the Deputy Dean for Academic and Student Affairs, Professors of the Faculty of Medicine, Universitas Andalas. Our speakers, Dr. Tom Wingfield, PhD, from the Liverpool School of Tropical Medicine, and Dr. Ahmad Fuadi, MSc, PhD, from the Faculty of Medicine, Universitas Indonesia. Managers, Head of Secretariat, Department Head, Study Program Head, Faculty Member, invited guests, students, and all attendees. Praise be to Almighty God for His blessing and guidance, allowing us to gather here for the International Guest Lecture on addressing the social determinants and consequences of tuberculosis and research development in community and hospital. We send our prayers and greetings to the great Prophet Muhammad Sallallahu Alaihi Wasallam. With Basmalah, we officially begin the International Guest Lecture today, Friday, the 8th of November, 2024, here at Faculty of Medicine, Universitas Andalas. Ladies and gentlemen, let us begin with opening remarks from the Deputy Dean for Academic and Student Affairs of the Faculty of Medicine, Universitas Andalas. To Dr. Afrida MKes SPPKK are welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semuanya. First, thanks to God that given us an opportunity and we meet in this room in a good condition. And maybe for the first, for Mr. Tom, welcome to Faculty of Medicine, Universitas Andalas. And thank you for your coming at this afternoon guest lecture. And we hope we can conduct research and publication together and maybe make ongoing collaboration for the future. Dan untuk seluruh profesor, Bapak Ibu sekalian, serta seluruh mahasiswa yang hadir pada kesempatan ini, tentu saja hari ini kita memberikan apresiasi yang sebesar-besarnya kepada Departemen Ilmu Kedokteran Komunitas yang telah melaksanakan kuliah tamu pada hari ini, dan tentu saja kami berharap hal ini akan memberikan manfaat yang sebesar-besarnya terhadap perkembangan studi maupun penelitian yang akan kita rancang bersama Mr. Toms. Dan pada hari ini kami juga menyampaikan permohonan maaf dari Bapak Dekan karena ada suatu kegiatan lain, sehingga kegiatan ini kita buka pada siang ini tentu saja tanpa mengurangi makna kegiatan ini dilakukan. Dan untuk Departemen IKM, kami berharap bahwa kegiatan ini dapat menginisiasi prodi maupun departemen-departemen lain yang akan melakukan penelitian bersama Mr. Toms, dan kami kemarin sudah mendengarkan juga penelitian-penelitian yang sudah dilakukan oleh Mr. Tom bersama dengan Fakultas Kedokteran Universitas Indonesia dan IMERI. Dan tentu saja kita berharap bahwa apa yang sudah dilakukan dapat juga dilaksanakan atau diimplementasikan di Fakultas Kedokteran kita ini. Tentu saja untuk seluruh mahasiswa baik itu program sarjana maupun pasca sarjana serta profesi agar dapat memanfaatkan kegiatan ini sebaik-baiknya. For Mr. Tom, this afternoon guest lecture will attended by undergraduate program and postgraduate program Faculty of Medicine Universitas Andalas. And now, dan selanjutnya kita serahkan mungkin kepada Departemen IKK agar dapat menindaklanjuti kegiatan ini dan mengimplementasikan apa yang sudah direncanakan pada hari ini. Mungkin dengan mengucapkan Bismillahirrahmanirrahim, kita buka secara resmi kegiatan ini. Sekali lagi mudah-mudahan bermanfaat bagi kita semuanya. Bila taufiq wal hidayah, wassalamualaikum warahmatullahi wabarakatuh.
Okay, ladies and gentlemen, before we go to the next agenda, we invite our speakers to receive the certificate and souvenirs from Faculty of Medicine, and we invite to the Deputy Dean for Academic Student and Affairs, Dr. Efrida, to the in front of the stage to join with us. Baik, terima kasih kepada Bapak Ibu pimpinan untuk tahan sebentar untuk kita melaksanakan sesi foto bersama. Dan kami minta kepada Bapak Ibu pimpinan untuk mengambil jajaran tempat untuk kita mengambil sesi foto bersama. Untuk sesi pertama kita berfoto berlatar belakang layar. Kemudian sesi selanjutnya kita berfoto berlatar belakangkan audiens. Dan kepada seluruh hadirin mahasiswa kami harap untuk berdiri agar kita melakukan sesi foto bersama. Ladies and gentlemen, we go to the main session of this event, which will be led by our moderator, Dr. Vini Fitriani, SPAK. She is a consultant in pediatric respirology and serves as academic staff at Department of Child Health, Faculty of Medicine, Universitas Andalas, and M. Jamin Hospital, and also a member of the TB Expert Committee of the Indonesian Ministry of Health. To Dr. Vini Fitriani are welcome.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang semuanya. Good afternoon, Tom and Dr. Ahmad Fuadi. Yang terhormat Ibu Wadek 1, Dr. Efrida. Yang terhormat Ibu Dr. Rosvita Rashid sebagai Ketua Departemen IKM, IKK, dan KK. Yang terhormat Prof. Rizanda, Bu Siti, Dr. Siti sebagai manajer, dan Bu Adila sebagai Ketua Panitia, dan Bu Firdawati sebagai Ketua Prodi S1, dan spesial for Tom and Dr. Ahmad Fuadi that available here for give the guest lecture for our student. Dan teristimewa tentu para mahasiswa mulai dari undergraduate, pediatric residents, pulmonologist residents, and special for magister and doctoral program of public health. And today we will hear from Tom and Dr. Ahmad Fuadi about how to research to do the research in public health. The first one, Dr. Tom Wingfield from Liverpool University School of Tropical Medicine, and he is actually is infectious disease expert, right? But many activity of him cover the public health activity also. So you know that this time there is no limited of knowledge and science and activity. Tom will have the several many activity about the tuberculosis and other topic. Do the research and activity, and you can see in his TV. And now we are honored to hear directly from him about how to addressing the psychosocial support and develop the activity for the covered it in the field. And he have many study including in Mozambique, Peru, yes, and Nepal, yes. So we are honored to have the lecture from him. And the second, Dr. Fiadi is the researcher from University Indonesia. Maybe we invite Dr. Tom Wingfield to give a lecture, and time is yours.
Assalamualaikum. Hello, good afternoon. Thank you to Prof. Afriwardi, to Dr. Siti, to Dr. Rospita, to Prof. Risanda, to my medical student colleagues, master's colleagues, doctoral studies colleagues. It's lovely to see you all. It's quite scary to see so many people. Thank you for the warm welcome and the discussions that we've had about collaborations. And thanks for the opportunity to speak to you about research that I care about and I'm committed to addressing the social determinants and consequences of TB, tuberculosis. I spend about 3/4 of my time doing research with people like Masfwadi, and about 1/4 of my time as an infectious diseases physician in the hospital in Liverpool in the UK. And so I'm also happy to speak about combining a career in clinical medicine and research. So I think we all know what the social determinants of TB are already, but let's just go through them. So this is TB deaths per 100,000. And this is in Europe from the year 1750 at the bottom to the year 1950 on the right-hand side. And what do you notice about the rates of TB deaths in London, Stockholm, and Hamburg? What's happening over those 200 years? They're going down, they're decreasing, okay? And okay, that's fine, but you might want to think, well, that was before we discovered Mycobacterium tuberculosis, before Robert Koch discovered the bacillus down a microscope. It was before the first use of BCG in humans. It was before the discovery of streptomycin, so before we had antibiotics for TB. And it was before we had isoniazid as a preventive therapy for TB. So these rates of TB deaths going down had nothing to do with healthcare. It had nothing to do with medicine. It had nothing to do with diagnosis. What it was related to was decreasing rates of poverty, better living conditions in the home, less crowding, better working conditions. In Europe, there was, I know this is important as well in Indonesia, occupational health law, 4 laws, working laws came into play that protected people's health at work. And finally, people's nutrition got better over this time period. All of those things are the social determinants that cause this decrease in TB deaths. And that's why Rudolf Virchow suggest, I don't know, those of you who are medical students, there's a node, a lymph node that happens here called a Virchow's node. So Rudolf Virchow said that tuberculosis is a social disease. And that's no different today. It's the same today. So there's about 10, nearly 11 million cases of tuberculosis each year in the world. 1 in 11 of those cases is right here from Indonesia. And the key risk factor for TB, the key social determinant, is not enough food. It's the same world over. That is the thing that causes most TB in the world. You can see there that it's over 2 million. So 1 in 5 or 1 in 4 cases of TB are directly related to undernutrition. Obviously, depending where you live, the second bar, the yellow bar, HIV infection, if you live in a place where the background rate of HIV is 1 in 10 people, you can expect that HIV will contribute, but it still is nothing compared to undernutrition overall. And I just would draw your attention to alcohol, and in the red bar, especially for men in Indonesia, I think, is smoking. So there's a time bomb, I think, for both TB disease in the future and now from smoking in Indonesia. And diabetes is another important risk factor that increases individuals' risks by about 2 to 3 times of getting TB. And not only do these factors cause TB, but they also are the same factors that mean that people have bad TB treatment outcomes like death, treatment failure, loss to follow-up. And this is work from Sierra Leone done by my colleague, Dr. Rashida Fuad Kamara, who leads the drug-resistant TB program. And amongst about 700 people with drug-resistant TB in Sierra Leone, you find also that undernutrition is a key risk factor for death, treatment failure, loss to follow-up. But importantly, other things like HIV, not on treatment, and chronic non-communicable comorbidities like chronic lung disease and chronic kidney disease also are associated with bad treatment outcomes. What about children and young people? This is work from Luisa Censina that we published a couple of years ago, looking at all the young people, 10 to 24 years old in Brazil, who had drug-sensitive TB, 200,000 people over many years. And again, we found similar things, these social determinants. So low education levels, drug use, homelessness, and again, HIV were all associated with having a bad TB treatment outcome. Importantly, if you got government cash transfers that we know most people use for food, then you had a lower likelihood of having a bad TB treatment outcome. Not medicine change, just money actually helped people to stay on TB treatment. So we talked about what causes TB and what causes bad outcomes of TB, but what are the social consequences of being a person with TB? So what happens to people with TB? This is work from Peru that's about 10 years old now, but we followed up 900 people with TB every 2 weeks through the whole of their treatment. And we asked them, how much money did you spend to get to the clinic? How much money did you spend on food because of TB? How much money did you spend on consultations with a doctor or a nurse? And we added those up and we looked at them according to their income, what the household earned. And then we decided on the y-axis there to look at their association with bad outcomes, just like I showed you on the last slides: death, treatment failure, loss to follow-up. And from left to right, you can see the same things come about. So people who were poorer, people who had less schooling, people who were more sick were more likely to have bad outcomes. But importantly, if you added up those costs of treatment and the loss of income from being sick, if that was more than 20% of your household's yearly annual income, then you had nearly a 2-fold chance of having a bad outcome. So costs matter. They're really important. And having catastrophic costs, as we define them here, led to a doubling of the chance of death, treatment failure, and loss to follow-up. So costs matter. Using this method and methods from other people, we were able to work with WHO to write the cost survey handbook to help people and countries to document the costs. And I know Mas Fuadi has been heavily involved in the cost survey, as some of you may have been too, in Indonesia. And now that method has been rolled out in more than 30 countries worldwide. And what does it show? Well, if you look on the left, this is for people with drug-sensitive tuberculosis, no resistance. 1 in 2 households have costs of 20% or more of their household income. If you imagine what your household earns in a year, 2 months of that, people are spending 2 months of their household's income on what is free treatment. So 1 in 2 people. And if you look on the right, the case is much worse for people with drug-resistant TB for 2 reasons. 1, the treatment is generally longer and harder. 2, they usually have already had TB in their household. They're already vulnerable. And so 4 out of 5 households with drug-resistant TB from these 30 surveys have catastrophic costs. So it's disastrous for people with TB, but especially people with drug-resistant TB. And it makes poor people who are already poor, poorer. They're worse off at the end of being sick. We looked into this in Nepal, and we found that about 60% of households in Nepal had catastrophic costs. But I want to show you this graph because I think it's quite important. So during the intensive phase of treatment, the first 2 months of treatment, at the top there, you can see the number of people in the household with poverty, in poverty, goes up. The household income in the middle goes down. And at the bottom, you see that the patient's income is virtually zero in the intensive phase. And what you'll notice is that if you go out towards the end of treatment on the right-hand side, the end of 6 months, that doesn't get much better, actually. Maybe a little bit better. But people at the end of treatment are generally poorer than at the beginning of treatment, and their households are too. So this is work by Ahmad that also shows from Indonesia. This is about 700 people in Indonesia. This Dr. Finney was involved in this work too. That shows that about 2/3 of people had what we would classify by a stigma scale as moderate stigma. Sorry. People, the reason for that mainly was that people were afraid. They had fear of telling people outside of their household. Half of people said, I need to think really carefully about who I tell. And on the bottom there, half of people felt guilty. And just today, we were in the Puskesmas here in Padang, and the same stories came about. Guilt, shame, fear because of TB. And this is important because it means that people find it hard to go to the clinic because they're ashamed. They find it hard to tell their family who can then support them. And it makes it hard for them to take treatment. In Nepal, we measured depression amongst people with TB towards the beginning of treatment on the left-hand side and towards the end of treatment on the right-hand side. The black parts of the bar show people who had major depression, and the grey show people who had mild depression. And this is work by Kritika Dixit, who just 2 days ago passed her PhD at Karolinska. So it shows that nearly 1/3 of people with TB had depression at baseline. And even at the end of treatment, you see that the black part has gone down, it's halved. So major depression is halved just by being treated. But still, nearly 1/4 of people, or just more than 1/4, have some form of depression at the end of treatment. If you look at control participants, people who do not have TB, the rates of depression are much lower than this. I haven't shown it here, but they're much lower than this. And to show again, it's persistent depression. So it gets better, but just like cost, it doesn't get completely better. And Ahmad has showed this as well in Indonesia, but Kritika showed it on the left is stigma score. From bottom to top is higher scores, worse stigma. From left to right is depression, with worsening scores of depression to the right-hand side. And they cluster together, that where you find depression, you find stigma. Where you find stigma, you find depression. And that's important because if we are going to address these issues, we have to do it together. You can't say, I'm going to cure stigma without thinking about depression. And the same for depression. You have to think about stigma. So some of this is quite depressing, isn't it? It's quite sad. It's really sad, but I'm going to try and show you how we can take that sadness and try and do something with it and address these social determinants and consequences of TB. And none of this is new. Does anybody know who this is? He discovered TB in Europe, at least. This is Robert Koch. So he discovered TB down a microscope in 1880. And Robert Koch himself, 10 years after his discovery, said one of the most powerful weapons we can use against TB is social welfare centers. So it was already recognized. What I'm talking to you about today in 2024 was recognized 134 years ago. And so Ahmad and I are late. We're late to addressing this, but none of this is new. But people are calling for it again. This is Professor Chakaya Mua, who ran the TB Union a few years ago, which is in Bali this year, and we're going to after this. And in 2021, he said, today I'm calling for coordinated multi-sectoral action to address the social determinants of TB by 2030. He says, we have done this before in high-income countries with great success. Would it be too much to ask for partners to target social drivers to end this disease in low and middle-income countries too? So I'm going to talk to you about 3 studies, one in more detail and the other 2 in less detail. This first one is from Peru. So Peru has 30 million people. It's a middle-income country in Latin America. And about 1/3 of people, 10 million people, live in Lima with the yellow circle, which is kind of has similarities to Jakarta. It's overpopulated. It's very busy, lots of traffic. The air quality is bad. And it has certain areas of quite severe poverty. And in Lima's case, I don't know about Jakarta, in Lima's case, some pockets of crime and violence. So we worked in an area just north of Lima on the outskirts that's really desert. It's desert dunes. And people who have come from other areas to seek work, to seek employment and money for their families have made their home in these dunes. And you can see the quality of the housing is quite low, cardboard, kind of wood, corrugated metal. And about 30%, 20 to 30% of people live on below the poverty line. And there are areas of these Callao which are very underprivileged and have, as I said, some gun crime and violence related to drugs. We did a study that built on the work of a wonderful team called the Innovation for Health and Development team, led by Professor Carlton Evans in Lima, Peru. And they had been working in Peru for about 15 years, looking at ways in which we could support people with TB socially and economically. Many different ways: vocational training, micro enterprise, microcredit, cash transfers, mutual support groups, education, public health campaigns. And we had used the best parts of all of these interventions, and we brought them together in a single intervention in a study called RECEPT, which sounds like producing a spit sample, like RECEPT, like getting a spit sample up, a household randomized evaluation of a socioeconomic intervention to prevent TB. Just to say in brackets, we've just finished the community randomized study. So the community randomized study is much bigger, and the results are going to be available soon. But this was the first study we did. So I'll talk you through the design. So what were we trying to achieve? The objectives were that household members of people with TB had to be screened for TB infection and disease. That if they were found to have TB infection, they should start preventive therapy. That people with TB were supported to take and to complete treatment, to become cured. So we randomized nearly 300 households, half of which received standard of care from the TB control program, and half received social and economic support in a package. The social support included household visits that happened at the beginning of treatment about 2 or 3 times by our brilliant nurses who gave educational messages about TB, much like happens in the Puskesmas already, who talked about household finances and how to manage the household purse, and reinforced the messages of the National TB Program. And then every month we held community meetings. And in these community meetings, we invited all the households from the district to come. And in the first half of the community meeting, we gave education through interactive presentations. And then we had TB clubs. TB clubs is where you sit together if you have TB. Somebody who is a survivor of TB leads the group, and you talk about your experiences of stigma and your experience and your journey through tuberculosis. And then you try to think, well, what are my rights as a citizen of Peru, in this case, Indonesia here? What should I expect from healthcare workers? How can I overcome depression and stigma? So it was empowerment as well as stigma reduction. So they were to educate, inform, and reduce stigma for TB-affected households. And then we provided economic support. So the economic support was conditional cash transfers. And these were worked out with the National TB Program to be equivalent to 10% of the household's annual income in this setting, which was the same as the costs from their pocket of that they spent on TB. And that was, so they had over 6 months, they could get up to $200. And the National TB Program felt that this, if it was targeted, could in Peru be sustainable. That was done through bank transfers every month. So what were the results of this combined package? Sorry, I should just say that the conditions, let me just see if I can go back. The conditions for these were that the households had to do everything in green. So as long as the household members were screened for TB, you started preventive therapy, you took treatment, and you came to the community meetings, that is when you could receive your cash transfers. So the results of this were good. So amongst contacts, people who lived in the households, we managed to increase the uptake and completion of preventive therapy by 44% in household contacts who are under 5 years old. In terms of TB treatment success, in the black bar, you have the intervention households, and in the grey bar, you have the control households who did not receive anything. And 76% of the intervention households achieved cure versus 63% of the patients in the control households. Now, this is generally, even in the intervention arm, you might say this is quite low. I know in Indonesia, you might have rates of 90% TB treatment success, but this was normal for the study setting we worked in. So we increased TB treatment success by 13%, an absolute increase of 13%. And if you found a new drug, a new medicine that did that, it would probably be rolled out quite quickly. What happened to catastrophic costs? On the right-hand side is the intervention households. And yes, their catastrophic cost proportion reduced. But even after all of that effort, the TB clubs, the meetings, the household visits, the cash transfers, still 29% of the intervention households still had catastrophic costs, which I think shows you the extent of the economic impact on people with TB in this setting. Peru is a middle-income country, and Peru has a long history of cash transfers. Other countries don't, and other countries are more suspicious or think that cash transfer would not work in their context, which is perfectly reasonable. Maybe food is better, maybe something else. But we tried to see if we could replicate the study in Peru in Nepal. So Nepal is a low-income country between China and India. About half of Nepal's population is infected with TB. It's one of the 10 leading causes of death, and they have about 70,000 new cases per year, which I know compared to Indonesia is small numbers, but for Nepal, with a population of 30 million, it's big numbers. It's a high prevalence setting. And about a third of the people who are estimated to have TB, or a quarter, die of TB. Very high death rates, mainly because of undernutrition. Many people in Nepal, a significant proportion, live below the poverty line, and less than half have any form of social protection like health insurance. The National Strategic Plan in Nepal from 2022 to 2026 said that they wanted to reduce catastrophic cost to zero. That was in their strategic plan as a key goal. So we worked since 2018 with multi-sectoral stakeholders, including the National TB Program, including people with TB, including social protection specialists. And together we developed, using some of the work that I've shown you before about stigma and catastrophic costs, a support package that we thought was feasible, potentially, acceptable, potentially, and scalable, potentially, in Nepal. And we put that into a pilot trial called ASCOT, Addressing the Social Determinants and Consequences of TB in Nepal, that was funded by the Medical Research Council. So in ASCOT, we weren't trying to test if it was effective. We were trying to test if the intervention was feasible, if we could deliver it, and if it was acceptable. So if healthcare workers said, okay, we think that this is acceptable to us, and if people with TB said, okay, we think that this is a good intervention and acceptable for us. And through the pilot, we wanted to refine the intervention ahead of a large-scale trial, which we're currently in the last stages of a funding bid for. And we did it in 4 regions of Nepal: Piutan, Chitwan, Mahotari, and Morang, which all have high rates of poverty and TB. And we randomized a small number of participants, just 128 participants, to 4 study arms. I'll explain why in a second. So the control arm got standard of care plus a food basket, nutritional food basket, one time. We gave that because we felt it was ethically appropriate that the people who were participating in the study received something. We gave social support only, no cash, no money. That included, from top to bottom, a wall calendar, so a illustrative wall calendar like you probably have in some of your sites here, about TB, messages about TB. We did mutual support groups, TB clubs, down there in the middle, like I've talked about in Peru, led by TB survivors. We made a video at the bottom, an animated video in Nepali language about TB stigma. And we also did home visits with education. In the economic arm, we gave 3,000 Nepalese rupees per month unconditionally, no conditions, at the beginning of the month. So you didn't have to do anything to do that, but we said we expect, we didn't condition, but we said we expect that you take your treatment. Why did we separate these two? We wanted to see if we could have good results from just social support, which is cheaper than economic support. And then the last arm was a combination of the social and the economic arms together. So the writing is small, but I'll talk you through it. I'll talk you through the results of recruitment, follow-up, and the different arms. So we had very good recruitment, 100% success rate in recruitment. Nobody said no to the study. We had generally good completion. We had generally good completion of over 90% of people were followed up until 6 months of treatment. So we had very little attrition. What about the acceptability and feasibility of cash, the home visits, the TB clubs? So most people had all 6 cash transfers every month. They completed them. And most people rated them as good or very good. They said these were good or very good. In the comments there on the right, people said that the money was timely, it was needed at that time, and that they could buy fruit and meat, which is sometimes quite expensive. And they said it helped to reduce the money they spent from their pockets. The home visits, again, were well completed and were very well rated. Said about good counseling and motivation. And people said they had the opportunity to ask about side effects. Side effects was really important. Some people felt they did not have the time whilst they were in clinic to ask about side effects. Sorry about this. Sorry, this is my family. Can I just check everything is okay? Just for 1 second. I want to check it's okay. Hey, I'm just giving a presentation. Are you okay? Okay. Sorry about this. I have 2 young children and I want to make sure everything is okay. Okay. So what's next? So the TB clubs is interesting. So the TB clubs, the people who didn't receive cash, we had low attendance at the TB clubs. We had less than 80% attendance. It's small numbers, but the people who didn't receive cash were less likely to come to the TB clubs, even though the cash had no link to the TB clubs. You got it anyway. But maybe this means that the cash enabled, allowed, facilitated people to come to the TB clubs. I don't know. People said the TB clubs were useful. They provided knowledge, that they liked sharing experience, and they felt that they would reduce stigma. So in the end, with Ahmed Fouadi and I, we decided with the team in Nepal to use socioeconomic support, because it seemed to be that had the best feasibility and acceptability. This was a small study, not expected to show any effectiveness, but just to show you the small numbers, that about 40% of people in the control and social arm who received no money had catastrophic costs, and about 20% who received cash had catastrophic costs. So even though it's not powered for that, I think these are quite tantalizing results. And finally, I'll talk to you about TB CAPS, which is the work that Ahmad and I are doing together. This is a mixed method study supported by Medical Research Council to implement a peer-led, community-based psychosocial support intervention. And this is where Dr. Finney is a key co-investigator too. And thank you to Andalas, Universitas Andalas, for your collaboration. It's really been brilliant. We were really focused on stigma here, trying to reduce stigma, and the study is TB CAPS. I won't go into it in too much detail, but the reason why we're doing TB CAPS and focusing on stigma here is that, as I've shown you before, 61% of people across 7 provinces, I think, Fuad, of 7 provinces of Indonesia, 700 people showed that they had stigma, 60% had stigma, and a third, more than a third, had some form of stigma. 6% depression, 6% had severe depression. And people on the third point there said that they did receive good levels of support from healthcare workers and from family. But what we found that was missing, so people said, yes, I received education from the healthcare worker. I got education for my family from the healthcare worker. I got emotional support from the healthcare worker. I got home visits in half the cases. So that was great. But the unmet needs on the right, we found that people wanted peer support. They wanted people who looked like them, who sounded like them, who'd experienced the same thing as them, to be helping them through their journey with tuberculosis. So 53% of people said that they needed that from peer support. They also said at the bottom there, nearly 2/3 said, we really need group counseling and individual counseling as well. So we built the intervention around what people had told us. We also did a multi-sectoral stakeholder workshop, participatory workshop, a national workshop, which was fantastic to try and say, what are the potential interventions and parts of the intervention we could use, and narrow them down through discussion, occasional arguments, Fuad, occasional heated discussion. And then we narrowed it down to this intervention on the right-hand side, individual assessment and counseling, where you talk about stigma, TB knowledge, you measure stigma, TB knowledge, depression, and then you invite people to monthly group counseling, which we did today in the Puskesmas. And that's with trained TB survivors and healthcare workers. And you talk more about stigma again. We try and set up some personal contact and group communication so that people with TB have a network, just like we all have social networks. And then we organize monthly talks in the community about TB and TB stigma, which anyone can come to try and spread the word. And we often find at these talks, it's a lot of women come to the talks. But women are often a way also to reach men. And globally, about 2/3 of people with TB are men. And more men globally are missed TB cases than women. So it's really important that we have a gender equality of trying to find women and men with TB. And I think there's still work to do there with this study. And then at the end, we're going to evaluate the acceptability, and we're going to look at people's knowledge scores and TB stigma scores and depression scores. So this is ongoing. We don't have results yet. We are finishing the follow-up in about March, and so we'll be writing that up from there. But it's going really well at the minute, thanks to all of your collaboration. So I'm going to finish here with the last 3 slides. So the bigger picture. So we've done a systematic review, a meta-analysis, which is under review with Lancet Global Health, that looks at social protection in tuberculosis. And ultimately at the bottom there, it shows that whatever the form of social protection, as defined by the World Bank, if you receive social protection as a person with TB, you are twice as likely to become cured as somebody who does not. It works. We have the evidence. We don't need more evidence about TB social protection. We already have it, but we still need to transmit that evidence to policymakers. You may have seen this study from India, which is called the Rations Trial. In this trial, the people in the red bar there, the red households, the person with TB in that household received a food basket. In the blue arm, everybody got a food basket. The person with TB and all their household members. And what this showed is that that nutritional support to all the household members decreased the risk of those household members developing TB by nearly half. This is not a vaccine. This is not preventive therapy. This is food preventing TB. The Rations Trial is really, really important. Please look it up. Because, for example, if you think, for example, you say to Fuad or I, cash here is not going to work, there are other options. There's food, there's insurance, there's in-kind support. We now have from the UN General Assembly a declaration and a pledge that by 2027, 100% of people with TB have access to a health and social benefits package. So, you know, these declarations are not always followed, but at least we have something to work with. We have a goal to aim towards. In the last month or two, or the last 6 months, we were lucky to contribute to this. Guidance on social protection for people affected by tuberculosis has come out from the World Health Organization. And we're really trying to encourage anyone to read it, to see how they might be able, have gaps in social protection in their country and to implement TB social protection. So finally, TB remains a disease of poverty, as it was for hundreds of years. It's associated not only with social determinants, but social consequences. So because you're poor, you get TB. Because you're TB, you become poorer. And because you're then poorer, you're more likely to get TB a second time, a third time. Pills, tests are great, but they're not enough. They're not working by themselves. And so we need social and economic and psychological support to end TB. And we have the evidence. So it's time to do this now, to end TB. Okay, terima kasih banyak.
Hello. Thank you, Dr. Tom, for the inspiring lecture. And I think we have the student to ask the question that maybe the student only know about the TB is a disease, not all of the aspects can we can see. So maybe you have a question from undergraduate or from the student from uh, Faculty of from Public Health Magister and Doctoral. Please, yeah. The first, second, yeah, okay. The third, okay, okay. The first one, please. Our undergraduate student.
Undergraduate students. The undergraduate students are very smart. You look very smart, all of you.
Thank you for the time and place. My name is Afi. I'm from the public health undergraduate. I would like to ask, as like you demonstrated before, that the economic household status impacts significantly to the poor outcomes of TB in terms making them more poorer, as you say, right? As a general practitioner, is there any way for us in Indonesia to advocate or intervene of this economic or cash issue? Maybe that's the question. Thank you.
Yeah, thank you. And other colleagues also, if you have responses, please do respond as well. So thank you for the question. I suppose the way I'd answer your question, first of all, is what I've shown you are what we would call TB specific social protection. So you have to have TB in order to then receive the benefits to stop you becoming poorer. To be honest with you, I don't know if you know the phrase "a drop in the ocean." So, it means that I personally feel that broader social protection, protecting people from food insecurity, making sure you have universal health coverage, as I know is a big theme here, and providing health insurance and decent education, those things are far more important than any of the things that I've shown you here, because not only will they stop, so the things I've shown you here are really just focused on the people who have got to the end stage. They've got TB, but what you want to do is prevent it, not through medicine necessarily, but through good nutrition or good. So I think advocating for social protection more broadly, especially for children, especially for undernourished families and very impoverished families, and bringing healthcare services as close to people as you can is far more important than anything that I've shown you in my presentation. I hope that answers your question to an extent.
For second question from, yeah. Introduce yourself, please.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Dr. Vini and Dr. Tom. My name is Anissa. I'm from student of Magister Hospital Administration Program. I wanna first of all thank you so much for your you come to our faculty to share your experience and knowledge for us to open our mindset here. Indonesian have 1,000 and more of type cultures here, and they become strong challenges for us to fight with tuberculosis. So these challenges are about education for people in Indonesia in treatment, especially about latent infection of tuberculosis. It's seems very hard here right now. Based from data in National Health Ministry Indonesia at 2022, the achievement of TPT is just about 2.6% from target 90%. So I want to ask you, please give us an advice or a perspective about this situation, and how about your experiences in other country like Nepal or other countries similar with Indonesia with fight with TB in the different culture here. Okay, thank you, Doctor.
Thank you, Anissa. So The first part of your question, I suppose, is can be answered more generally. Is that I'm not the person to ask about Indonesia, because I'm not from Indonesia. I don't know Indonesia well enough. From the outside looking in, and from my limited experience of discussing with expert colleagues and other people, is that you already have here, to overcome problems with language barriers, some structures in place to do that through community engagement. You have the way that the puskesmas are set up and the posyandu are set up are already integrated into communities. And so I think my answer would be that some of how you overcome the issue of different cultures, different languages, is through engagement and participation of those communities. How you budget for that and how you sustain that, and you ensure that community health volunteers are not being used without proper support or reimbursement or some recognition, I don't know. And that's a problem the world over, is that we rely heavily on community health workers and community health volunteers, but very little do we offer them something that means they want to continue doing that for years and years on end. In terms of TPT, around the world, TB preventive therapy is poorly given around the world. And I think there are a few different things that I could suggest with that. One is thinking about the way in which we identify the people most in need of TB preventive therapy, how we target them. So, for example, would there be a way in the future to do it so that the person with TB identifies people in their household with symptoms? You could do it so it's patient initiated. And in some cases, even in Mozambique, we're trying to do that through a mobile phone, because in some settings, even that are very poor, have very high mobile phone use, even more than clean water in some places. The other way is that the treatment for preventive therapy is long. It's mainly 6 months of isoniazid. And so that's sometimes hard to provide and hard to take. And if we could have shorter treatment regimens, even eventually in decades, I think we'll have injections, but I think that will help. I suppose a broader question would be, we need a good vaccine. So we wouldn't really need preventive therapy as much if we had a vaccine that worked. And BCG only works for children, and it only works for disseminated disease in children. It doesn't function in adults. So I'm hopeful. Sadly, for social protection, there's very little money has been invested in social protection, but for vaccines, much money was invested in 2023 at the UN high-level meeting. So I think vaccines alongside preventive therapy is important. But I don't have a great answer for your question overall, because it's a very complex issue that you've identified rightly.
Okay, the third question, Dr. Rudy. Yeah.
Thank you. I'm Rudy Alfendi. I'm a pediatric resident. So I'm so interested about stigma in TB. I have some question for you.
Yes.
The first, how long the stigma can be held in TB patient? If the patient was healed from TB, is the stigma will continue? And the second, in your opinion, what is the best intervention to decrease or remove this stigma TB? And the last, about stigma in adolescents. Is there differences between stigma of TB adolescents and adult? Thank you.
Thank you. Dr. Rudy, you said? Yeah. Okay, thank you for these are all excellent questions. Thank you. And you've asked 3 questions as well. Okay, so the first one, how long does stigma last? I suppose it depends on what stigma you mean. So we think about stigma as community level stigma. What do people in the community say about people with TB? What do they think about people with TB? When you talk amongst a group of friends, how do you refer to a person with TB? So that's the community level stigma. So that's, and that may manifest by a member of the community enacting stigma. So saying, don't come near me. I don't want you near me, right? The other stigma that we try and address is self-stigma. So I feel, if I've got TB, I feel dirty. I feel unclean. I feel ashamed. I feel guilty. The way you address those two things is very, very different, because community level stigma requires probably public health messaging on radio, on television, through elders in the mosques, through imams, through mothers, through the community. Whereas self-stigma, I think, requires you to sit with somebody with tuberculosis, to have somebody like a survivor to share their experience, like we're trying to do, and to gradually feel that I'm not dirty. I don't deserve this illness. It's not my fault I have this illness. And it is an illness like any other illness. It's like diabetes. It's like anything. And I think once you can empower somebody to do that, but I think that is a different approach. It's a much more closed, supportive, personalized approach. So I think I've kind of answered two of your questions there. The third question about adolescence is, I do believe that adolescents experience stigma very differently. And I think that the way that you would address adolescent stigma is also very different. I don't know exactly how it functions in Padang or in other parts of Indonesia, but adolescents are, if they've got a phone, that's their network. Okay, not everybody has it. Rural areas may not have phones, but their network of people is their friends are sometimes as important as their family. And so I think that actually trying to do things that are interesting for people, for adolescents, that are not boring, not dry, interactive. Maybe there's been stuff to do with gaming for stigma for adolescents, you know, computer games, comics, things that they normally interact with, Facebook groups, what have you. So I think that's one way to reach adolescents, but you can also engage adolescents to work with other adolescents as well. And we just put in an application in Africa to look into that very question about adolescent stigma. Because when you're a teenager, it's such a sensitive age. And so it can be very important to support teenagers through that time. But for me, I would also suggest you focus, if they have a good family, on family interventions. You work with mummy, daddy, granny, auntie, uncle, cousin, to try and get the support system they have from the family to really hug them and help them through that treatment, and their friendship group. Yeah, so it's a slightly different approach, I agree. Finally, how long does stigma last? I think some people who've had TB will have stigma for the rest of their lives. But most people, it's not really about having the disease. It's about how you look. You're very underweight. It's about how you cough. It's about people's response to you and your own feelings of value. If you can't work anymore, you can't provide for your family, you can't do household chores or household activities like normal, you lose your value of yourself. And I think that can stay with people a long time. And that's why we try and overcome that with counseling, like we're doing now. You're not valueless. You have as much value as you ever did. You will get better and contribute like you want to in the future.
Thank you, Dr. Tom. I think this question is very good, and the response from Tom is have the high value for our perspective. And again, we give the applause for Tom. Maybe we can sit again, but maybe we can invite you for the panel discussion after this. If you still have the question, you can prepare for a panel. Okay, the second one of our speaker for this afternoon, Dr. Ahmad Fuadi. Okay. Dr. Ahmad Fuadi is a lecturer in ilmu kesehatan IKK, ilmu kedokteran komunitas. Kalau di kita di IKM-nya ya Prof. Dr. Oos, jadi di FKUI. Beliau menamatkan pendidikan PhD di Rotterdam, Belanda tahun lalu, 3 tahun yang lalu, dan saat ini aktif di riset TB, health economic, dan juga konsultan BPJS ya. Ya, pokoknya banyak deh. Kalau di IG cari aja Ahmad Fuadi, Anda akan suka lihat. Dan beliau juga penulis dan ustadz ya. Penulis dan banyak di Facebook juga ada. Jadi silahkan di search ya. Oke, we invite Dr. Ahmad Fuadi to give a lecture about how to collaborate the research, have the research collaboration with a broad and multidiscipline approach. Please, Dr. Ahmad Fuadi, time is yours. Jadi saya pertama kali lihat Mas Ahmad Fuadi ini di Facebook. Setelah itu saya menjadikan beliau idola. Akhirnya bekerja sama ya. Oke. Silakan Mas Fuadi.
Ya. Assalamualaikum warahmatullahi wabarakatuh. Pembukaannya harus Ustadz ya. Karena di Padang. Okay. Should I speak in English or in Bahasa? It's up to you. Both? Ya, kalau saya kesusahan ngomong bahasa Inggris, saya pakai bahasa Indonesia, oke? Okay? Okay, thank you very much for the opportunity to share my experience in front of you in Andalas. It's a very bright students from undergraduate medical school, graduate IKM, Kesehatan Masyarakat, Public Health. I want to introduce myself. Actually, I'm a medical doctor, but not practicing anymore at this time. So I decided after my PhD and my postdoc, I did my postdoc in WHO, International Agency for Research in Cancer, as a health economist, and then returned to Indonesia. And I decided not to practice anymore and focus on the research in health economics and policy. But before I pursue my PhD in the Netherlands, I have a lot of experience, as you said, about how a primary care physicians deal with the socio-economic issues of the patient. It was also the reason why I choose health economics and policy. When I did practice in my clinic, I did in a family clinics and in some private clinics. Some patients came to my clinics, also with tuberculosis patients, and they come to me after they did another treatment, tuberculosis treatment. So I will also combine it with socioeconomic issues amongst people with tuberculosis is really closely interrelated with stigma in Indonesian context. Because people, when they feel they have enough money to treat or to seek care and feel that tuberculosis is kind of a poverty issue, they choose or they decided go to the private providers, into private clinics, into private hospitals, because they don't want to be recognized as being diagnosed with tuberculosis, right? But after 1 month, after 2 months, they also aware that, oh, the treatment is expensive. I'm getting better. So I don't need to take any treatment. And they lost to follow up. But after 2 months, they also experience another symptoms and sign. And then go to the private providers anymore or go to the puskesmas and say that I went to the private clinics, but I don't have any money. Or come to your clinics and you are the private you are the primary care physicians and say to them, why did you choose go to the private clinics when in puskesmas it is free treatment? But they don't know about the free TB treatment in Indonesia. It's just quite long ago, in 2014, before the national health insurance is implemented in Indonesia. So I suggest them, I advise him, I advise them to go to the public health providers to go for the free TB treatment, and it can help the socioeconomic issues of them. Even though this is about the patients with, they think they have enough money. But there are also some patients with a poor economic status. They went to the puskesmas, they feel stigmatized in the community. And you know that some patients don't go directly to the puskesmas, but they went around, travel around, just not to be recognized as being diagnosed with tuberculosis because they afraid to be recognized as tuberculosis. So there are some issues. So as primary physicians, as a doctors, I think you should or we should treat the patients as a person. You know what are their concerns. It is not about their disease only. It is not about the bacteria. It is about the person you should treat. It is not about you give this is a treatment, this is a TB drugs, you have to complete it, otherwise you will have a relapse. But think about their mental, their spiritual condition, their socioeconomic condition, because it can affect their treatment completion. Okay? And this, after that, and then I learned about this, and then I pursued my PhD and my master of science and health economics, because I think it is not only about being a good doctor, but I want to be a part of those who can improve the health system, give them provide the free healthcare access, and how to improve the social health protection in Indonesia. So I want to share about the developing research in community and hospitals. When I was in medical students, I was not a students who are in love with research. Not the kind of that students. I'm afraid of research. I was afraid of research. I didn't like it. But you know, after I graduated from medical schools, and I had an opportunity to go to Padang for earthquake disaster reliefs in 2009, West Sumatra. And my supervisor, Dr. Mukhtar, Dr. Mukhtar asked me to go to Padang, see, and then get some data from them, make a recommendation for the provincial health offices, use the data, and publish it. I think it was very, very difficult for me as a new, freshly graduated student. And then I just tried. Yeah, just write, blah, 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 the proposal, just write the papers, and my supervisor just with a lot of scratch. A lot of risk. But don't worry. But because after that, I feel that it was very useful for us to improve. And get the confidence. So my question is, here, kemana nih? Salah. Gak bisa? Ya. Klik. Why do we do research? So the important questions for us is, why do we do research? Some of us it is an obligation because I am a medical student. I have to have a research for to pass my exam, or I am a medical staff. I am a academic staff that I have an obligation at least one research for 1 year. So, what is about the accreditation? Ya, apakah ini karena besok harus akreditasi, saya harus punya riset? Apakah itu alasannya? Or do we do research because we want to learn something new? Yeah. Or we want to hone problems solving skills of ourselves, produce new knowledge, challenge yourself in new ways, and whether it is self-actualization of ourselves. Apa sebenarnya tujuan? Kenapa saya harus melakukan riset? Apakah hanya saya punya kewajiban riset, yang penting lewat? Ya. Atau memang saya mau mendapatkan satu pengetahuan baru? Nah, saya mau men-solve problems. Because many people comes to me from hospitals, from BPJS Kesehatan, from Dinas Kesehatan. They ask about how to solve this problem. And I ask them back, do you have any data that can inform you what strategies that you have to do? The first thing adalah, yang paling pertama adalah critical thinking. Anda punya problem kita banyak. Di dunia ini toh, di hidup kita juga banyak. Mau beli, saya tanya, mau beli motornya NMAX atau Beat aja? Beat. Atau mau beli Avanza atau mau beli Expander? Apa yang pertama kali kita kerjakan? Ya, spesifikasi. Lihat Instagram. Mana yang paling bagus, mana yang paling banyak dipakai. Ada satu teman saya itu selalu punya begini. Setiap kali ada sesuatu, dia melakukan riset. Bahkan untuk pergi ke restoran yang mana, saya datang ke Padang misalnya. Saya mau pergi ke restoran yang mana, yang dilakukan apa? Buka Google, baca review. Ya kan? Apa enggak? Just go anywhere. What I do, saya belajar bahwa setiap kali pergi ke satu tempat, saya melihat reviewnya, saya memutuskan pergi ke situ, lihat bintangnya 1, bintangnya 2. 4,8 atau 4,3. Tapi lihat kemudian, skip yang lain, kalau bintang 1, kenapa bintang 1? Kenapa dia bintang 2? Kenapa dia bintang 5? Pernah nggak kepikiran kayak gitu? That is kind of research, I think. Simple research in our daily life. Buat saya itu lebih memuaskan karena saya mencari sesuatu yang saya harapkan. Oh, ini bintang 1 karena ada kecoanya. Otomatis saya nggak akan pergi ke sana. Kalau bintang 1 karena parkirnya nggak cukup. That's fine. Saya pergi ke sana nggak usah pakai mobil, saya pergi ke sana pakai Gojek. Nah, daily life, mau beli motor yang mana? NMAX, Yamaha, bla bla bla. Kita pergi research, baca reviewnya, ya kan? Baca reviewnya, baca orang, experience orang. Mau beli handphone juga begitu. And that is kind of research in our daily life. Kenapa kita juga nggak membuka peluang itu di daily life yang lain? Nanti kerja di rumah sakit, nanti kerja kan rumah sakitan kan? Setiap hari punya data, datanya seabrek-abrek. Dan sekarang nanya, ini kenapa ya kita rugi terus? Banyak yang nanya kayak gitu. Kenapa rumah sakit saya rugi terus ya? Lihat nggak datanya? Oh iya ada datanya. Pernah nggak dianalisis? Ya kadang-kadang datanya di kertas. Susah masukin ke sistemnya. Susah di Excelin. Ya. Kalau kita punya satu pertanyaan penelitian, kalau research question, kita punya satu pertanyaan masalah dalam hidup pekerjaan kita, make it systematic. Berjadikan itu pertanyaan yang sistematis dan langkah-langkah yang sistematis. Kalau gitu, saya harus jawab pakai apa? Hipotesisnya apa? Kan dia jadi gitu ya. Hipotesisnya apa? Terus saya harus jawab pakai apa? Oh, pakai data medical record, pakai data farmasi, pakai data billing. Dan ternyata kalau dicek, banyak sekali orang yang berpendapat bahwa saya habis JKN itu rumah sakit saya rugi. Rumah sakit saya rugi. Kenapa rugi? Pernah saya lihat datanya. Oh, karena kita akhirnya mereka motong. Kalau pasien udah 3 hari dipulangin, 3 hari dipulangin gitu ya. Sekarang 4 hari dipulangin, pagunya lewat dipulangin. Padahal proses paymentnya udah berbeda. Pernah nggak dia pakai big data, terus ngelihat patternnya, polanya, mana sih yang paling banyak, mana yang menguntungkan ketika dia disubsidi silang, sehingga kita sampai ke satu tempat, okay, this is the kind of remuneration that we have to apply in our hospitals. Yeah. Okay. Start from small step, because human are always learning from experience and from interacting with the world around them. Dan itu juga kan ngomongnya sama orang Padang jadinya. Kalau di Quran juga begitu kan. Quran juga ngajarin lihat matahari, lihat bintang, lihat langit, lihat unta, lihat gunung. This kind of kenapa sebuah health program? If you are working at Puskesmas and you did see that one program did not run well, our target is 70% and our achievement is only 50%. How can it happen? Lakukan program evaluation. Diajarin program evaluation di S1. Program evaluation is kind of research. Why do many people with hypertension, for example, not achieve normal blood pressures despite the Puskesmas has been done? Puskesmas sudah ngerjain macam-macam, tapi banyak sekali yang hipertensinya tidak terkontrol. What do you do? Community diagnostic. Yeah? What happened in the community? What happened among the people with hypertension? Why does the antibiotic resistance in ICU increase? In which population? In which patients with special characteristics? And why does the hospital keep losing profit? Tadi yang seperti saya sampaikan. And this is one. What we need to start. This is the first international publication of mine after I graduated from medical students. So primary healthcare center disaster preparedness. I went to Padang. I see the Puskesmas. I saw Puskesmas. I learned with them and we built like a disaster preparedness. And I think it is not about work burden. Every work burden, there is always opportunity to improve. Yeah, it is opportunity. Sehari-hari kerja, Banyak banget masalahnya, banyak banget kerjaannya, but look that behind your burden, there is always opportunity to improve. And the second is seek guidance, mentorship. Cari seseorang yang bisa bantu kita untuk mengarahkan harusnya saya gimana. Siapapun. Ketika saya selesai dari sekolah kedokteran, yang saya lakukan adalah saya silaturahmi ke beberapa orang yang saya anggap bisa bantu untuk guide saya, mana yang kira-kira saya harus kerjakan. Cari ngobrol sama beberapa orang, dan saya ketemu satu orang yang bisa, saya pikir dia bisa membantu saya untuk berkembang. Saya bilang, do you want to be my mentor? Do you want to supervise me to improve? And then he said, yes. Okay, seek guidance, do a mentorship, be a good mentee also. A good mentee, kita harus punya persistensi juga. Yang ketiga adalah one small success give you courage and confidence. Dream big, selalu berpikir tinggi, besar. Oh, saya mau ke Lancet. I want to publish in BMC. I want to publish in an EJM, for example. But before you do it, small success, pergi ke Sinta 1, Sinta 2, Sinta 3. Karena yang kita butuhkan di awal-awal pekerjaan kita adalah confidence. Masuk nih, ada orang yang kemudian, aduh capek, malas report, malas riset. Dia langsung maju ke Q1, dibabat sama reviewersnya, terus hilang semangatnya. Jadi, mulai dari small grant. Small grant, mulai dari mahasiswa cari biaya funding untuk ngajain risetnya. Nanti pada saat staff, ada skema-skema 10 juta, 20 juta, 50 juta. That's not problem. We are not rising like a $1 million grant, but doing with the small one. Small grant, small publication, because itu yang akan membuat kita jadi punya semangat. Saya bisa loh. Saya ternyata mampu loh. Itu yang tadinya mengubah saya, yang tadinya nggak suka sama sekali riset, yang ketika disuruh bikin metodologi dan dicari-cari sama mentor saya, udah selesai belum metodologinya? Saya gitu. I don't know. Menulis metodologi aja saya nggak bisa. But small publication give you confidence and small incentive and acknowledgement. Ini buat guru-gurunya yang ada di sini. Kalau muridnya lagi berusaha keras untuk melakukan riset, give them incentive, give them acknowledgement. Karena itu yang membuat mereka jadi senang. Makanya setiap kali ada mahasiswa baru datang ke saya selalu senang, oke, apa yang bisa saya bantu? Karena saya melihat, I reflect myself 15 years ago, 10 years ago, when I did not know anything about research. So I want to help them. Okay? And then work as a team. Buat yang staff, even to become a professor in Indonesian system, you need a work team. You need strategies, right? Kita butuh melakukan strateginya. Saya mesti ngapain? Kalau saya butuh di Q1, kalau saya butuh di Scopus. Oke, saya nggak bisa diem dong. Saya harus cari dong. Mana yang bisa bantu saya? Timnya bisa bantu apa enggak? Dan kalau sudah ada timnya, take a responsibility in the team. Oke, saya mau nulis. Bantu saya belum bisa. Saya kerjain. Ayo. 3 strategies. Kemudian define siapa yang harus melakukan apa, kapan melakukannya, dan bagaimana melakukannya. Ya. Kemudian, set targets. Apa target kita? Bahkan kalian sudah jadi student, sudah mau berkembang sebagai satu institusi atau satu kelompok orang, set targets, set benchmark. Ya. Kalian punya target, kalian punya benchmark. Benchmarknya siapa? Saya mau kayak dia. Saya mau kayak institusi ini. Kenapa sih saya pengen? Karena institusi itu begini. Karena orang itu saya lihat A, B, C. Benchmarking is important. Kemudian sudah punya target, sudah punya pathway, sudah punya benchmark, dan seek collaborators. Cari kolaboratornya. Siapa sih? Oh, saya maunya gini. Berarti saya harus cari. Apa yang saya pernah lakukan? Yang kita lakukan adalah saya buka referensi, Google Scholars, and jangan pernah takut untuk approach orang penulis di artikel yang kita enggak pernah kenal. Approach them. Send an email. Ask, what do you think that you don't understand? Even there is no silly question. I read your paper, but I don't understand. Yeah, can you explain to me? I read your articles, and this is very interesting, and I want to do some works, blah 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 blah. Do you think that I can work with you? Something like that. Anda mau master, Anda mau PhD, Anda sudah selesai PhD, keep Anda humble dan bertanya bahwa kita tidak pernah tahu apapun segalanya, semuanya. Oke, baru yang terakhir seek funding. Ya, seek funding. Grant funding. Saya selalu suka sama gambar ini karena waktu saya kemudian sudah punya tim, sudah punya orang, apa yang saya lakukan? Saya mau jadi machine gun, or I will do a sniper. Every opportunity, if you are doing machine gun, in every opportunity you, at least within 100 shot, and then you get one, for example, it's machine gun, but it takes much effort. Capek. Dan kalian coba, sama ketika kita nyari scholarship. Buat teman-teman yang nyari scholarship, dan nggak punya, saya mau jadi apa ya? Biasanya kita pakai machine gun. Oh udahlah, LPDP, bravo. Udah, semuanya diambil. Pokoknya satulah yang nyangkut, dua yang nyangkut. Atau, kita pakai pendekatan sniper. Sniper itu, saya mau yang ini, saya baca kesempatannya yang kayak begini, ini gak cocok, nggak usah. Ini cocok, tapi setengah kayaknya. Ini yang cocok banget nih. Oke, kita berusaha untuk yang cocok banget. Itu sniper. Ya. Mana strategi yang mau kita pakai? Kadang-kadang teman-teman yang datang atau junior-junior saya yang datang, dia coba semuanya. Ketika dapat 3, dia bingung. Saya pilih yang mana ya dok? Dapat LPDP, dapat 3 LOE. Terus dia bingung, dia mau, kamu mau jadi apa? Bayangkan dirimu 10 tahun lagi, mau jadi apa? Bukan salah, tidak. This is opportunity. But it help to shape us. Itu bantu buat kita untuk, apa sih sebenarnya yang kita mau? Ada 3 pilihan lebih bagus daripada tidak ada pilihan sama sekali. Sekarang tinggal, kalau kita punya 3 pilihan, saya pilih yang mana? Do some research. Lakukan lagi, riset lagi. Risetnya bukan keluar doang, tapi riset ke dalam diri sendiri. Saya mau jadi apa? Oke, machine gun or snipers. And then, jangan pernah takut. Belum. Hilang. Ya, failure is not the opposite of success. It is part of success. Jangan pernah takut untuk fail, karena itu bukan opposite, bukan lawannya kesuksesan. Tapi itu bagian dari kesuksesan kita. Ya. Kenapa? Selama kita mau belajar, kemarin kenapa. I want to share to you. Ketika pakai bahasa Indonesia biar gampang. Tahun 2013, saya selesai master student di Netherlands. Kemudian saya apply untuk beberapa posisi, salah satunya adalah posisi WHO. Saya lihat, oh ini kayaknya cocok. Tapi lokasinya di Perancis Tengah, Lyon namanya. Saya apply. Nggak pernah dipanggil. Baliklah ke Indonesia jadi dosen. Ya. Kemudian, Anda tahu, selesai saya PhD tahun 2020, tiba-tiba ada seseorang yang nelpon atau email saya, dia bilang, maukah kamu saya interview minggu depan? Dari mana? Dari institusi yang 6 tahun sebelumnya kontak saya. Saya kontak, saya apply di situ. Pas saya lihat, loh, ini institusi yang 6 tahun lalu saya apply berkali-kali nggak pernah masuk. Dan tahu saya apply berapa kali? 15 kali. Buat postgraduate saya apply 15 kali. Sampai saya bilang sama Allah waktu itu, ya Allah, ini aplikasi saya yang terakhir. Kalau emang bukan jalannya, udahlah saya berhenti aja. Saya berhenti aja waktu itu. Saya berhenti apply postdoc, saya balik ke Indonesia. Ya. Ditunggu, nggak ada jawaban. Dan saya akhirnya ngerjain hal yang lain. Tiba-tiba menjelang Ramadan pada saat itu, seseorang email, aku lihat aplikasimu, aku lihat kerjaanmu, I'm interested to invite you to work with me, katanya gitu. Aku lihat, karena dia lihat PhD buku PhD saya, dan kemudian dia bilang, bisakah kamu ngerjain itu, yang di tuberkulosis, bikin buat di cervical cancer. Terus dia bilang, aku pikir-pikir dulu ya, saya bilang gitu. Terus dia bilang, oke, berapa lama kamu pikir? Kamu bisa datang bulan Mei, Juni, Juli, Agustus? Dan itu setelah saya datang ke sana, oh ini sesuatu yang 6 tahun lalu saya apply di situ. Dan it is not a failure. Failure is not opposite of success. Anda bisa mengerjakan itu, ini adalah bagian dari sukses ketika kita coba untuk belajar kenapa sih kemarin saya salah, kenapa sih saya nggak bisa tembus-tembus, dan lain-lain. Tentu saja itu merupakan bagian juga dari takdir Allah yang selalu bikin kita harus tetap sadar bahwa despite our success, there is always God who decide your destiny. Supaya kita nggak sombong. Oke, terima kasih, itu saja dari saya. Mudah-mudahan bermanfaat. Saya nggak lecture, saya cuma share my experience aja ya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ahmad Wadi. Please sit here. Yeah. Tom, I invite you to sit here again. And I think you can still, if you can still have 1 and 2 questions for Tom, you can ask. Okay, Dr. Wadi, it's very inspiring talk, I think, because you have many failure, but you have many opportunity and have many success also. So maybe we have time to question from the audience. Undergraduate. Jadi Dr. Fuadi ini 2009 ke Padang Pariaman. Ya, saya aja terkurung di rumah. Dr. Fuadi udah sampai di Padang Pariaman ya, menjadi relawan gempa ya waktu itu. Nah itu baru kayak anda inilah ya, kayak adik-adik ini ya, baru selesai koskap ya, baru selesai. Silakan, ini juga ada bapak-bapak dari bapak ibu dari S2 Kesmas dan S3 Kesmas yang sedang menyusun proposal. Tadi sebenarnya nggak terlalu berat, untuk siang ini itu ringan, tapi itu penting semuanya. Gitu ya. Silakan. Ya, oke. First, Dokter Tiwi ya. Dokter Tiwi ini dokter di puskesmas, tapi aktif di TB juga. Silakan Dokter Tiwi. Dr. Tiwi is a general practitioner in puskesmas, but active in our TB program.
Assalamualaikum warahmatullahi wabarakatuh. Izin mungkin dalam bahasa aja, Dok, karena pertanyaannya untuk Dr. Ahmad Fuadi. Saya Dr. Pratiwi dari Puskesmas Andalas. Jadi buat hadir ke sini juga WA sama Dr. Vini, Dok, saya boleh ikut nggak ya gitu. Jadi alhamdulillah saya sudah 5 tahun di Puskesmas dan materi Dr. Ahmad Fuadi ini menjawab beberapa pertanyaan kami gitu. Jadi yang ingin saya tanyakan adalah bahwa di puskesmas itu data banyak sekali, Dok, gitu. Data banyak gitu ya, karena kita programnya begitu banyak termasuk semuanya baik TB, gizi dan yang lain. Cuma memang kita di dokter umum di puskesmas itu mungkin butuh kolaboratornya adalah dari kampus gitu sepertinya, sehingga kami juga bisa dituntun ya, dituntun untuk bisa mengerjakan penelitian yang datanya dari puskesmas, sehingga kita bisa bareng-bareng gitu cari solusi dari masalah kita di puskesmas gitu. Jadi mungkin, apakah memungkinkan gitu sebuah penelitian itu, memang dikerjakan oleh kami di dokter puskesmas, mungkin berkolaborasi dengan dosen-dosen kami di fakultas, sehingga kita bisa mencari, solusi dari masalah-masalah yang ada di masyarakat. Selama ini mungkin, kita punya dokter muda di IKMKK yang nantinya, biasanya berpraktek di puskesmas. Dan kebetulan saya juga menjadi salah satu pembimbing mereka di puskesmas, cuma memang, eee, pembimbingnya juga perlu dibimbing gitu, sepertinya gitu. Karena biasanya kita ke, dokter muda kan biasanya kita sampaikan apa saja program evaluation yang ada gitu, evaluasi program kita yang ada setiap tahun dan yang lainnya gitu. Jadi mungkin mohon masukan, Dok, apakah memungkinkan bagi kami untuk berkolaborasi dengan fakultas dan mungkin kami juga perlu apakah, ada event ataupun pelatihan yang membuat kami bisa conduct riset yang bagus gitu dan datanya itu bersumber dari puskesmas gitu, karena data puskesmas itu sangat banyak dan sangat mungkin untuk bisa digunakan. Terima kasih banyak, Dok. Assalamualaikum warahmatullahi wabarakatuh.
Tes. Yeah. Thank you for the questions. I think it is very important to discuss about the collaboration between puskesmas and academics in university, because there are two interests. Yeah, I remember that when I proposed a study and I went to puskesmas, to the head of puskesmas, I explained about my plan, the study plan in the puskesmas, and it was rejected by the head of puskesmas. It was very shocking for me because the head puskesmas said that your study will not solve any problem here. So I was shocked, and then really. So at the university, we think about something advanced, something that's very robust, but the robustness of our study, sometimes it didn't solve anything in puskesmas. Puskesmas wants to seek something that operational in their daily work. So I think this is also how to communicate between healthcare providers and the university. And I hope that Puskesmas and Universitas Andalas, we call in Jakarta, we have academic health system. I think it's also happened in Universitas Andalas or other university. Academic health systems is to encourage any collaboration between the university and healthcare services around the university, surrounding the university, within one district or cities or one province. And I think it first communicated with any university staff here in Faculty of Medicine. The first. The second one, if there are any opportunity, I think you have an opportunity to also supervise medical students when they do their clerkship in Puskesmas. And because of that, you have an opportunity to learn also from the academic, right? For example, evaluation program, community diagnosis, and then you learn from them. And if there is any problem, there is any things that are not clear enough, yeah, because I also work in a community medicine and I run a module of MPI, pre-internship, and also SPKP, primary care system. Yeah, I work a lot with the Puskesmas supervisors. And if they don't understand what is program, what is program evaluation and community diagnosis, they can ask. Yeah, and this is an opportunity for you to also collaborate. The third thing is just seek one or two that you know. For example, Dr. Fini, Professor Rizanda, and then ask, can you be our mentor? We want to improve our Puskesmas. We have the data. It is not important to have a large team with a many academic university staff, but just one or two of them, and then set some targets. Kita mau ngapain? Saya butuh ini, saya butuh itu. Bisa nggak kita kerjakan? Yeah, and then you can balance between academic university targets and your targets, because academic university targets, they think always about it can be published. Bisa nggak ini dipublikasi? Bisa nggak datanya bagus apa enggak? Kalau berpikir seperti itu terus, ya, datanya di Puskesmas ada, tapi pasti tidak sebagus kalau kita melakukan penelitian yang betulan. Ya kan? Nah, sekarang kita coba cari titik poinnya. Oke, kita ngerjain ini, terus kita bantu pakai apa nih? Ada yang namanya one of terms is about operational research. Saya mau memperbaiki HIV, program HIV. Saya mau memperbaiki program kesehatan ibu dan anak, datanya kayak gini. Terus kita pakai studi kasus, dan selalu ada kesempatan ini jadiin presentasi di mana? Di conference. Ini walaupun itu nggak jadi publikasi, dia jadi presentasi. Buat ibu, buat dokter-dokter di Puskesmas, tentu ini juga membantu kan. Kita mau ngapain nih setelah ini? Nah, saya pikir itu duduk bersama, set targets, dan kemudian apa yang mau kita kerjain. Terus dua kepentingan yang sama-sama ada di situ, kita harus cari titik temunya. Bapak mau apa, saya mau apa. Ibu mau apa, saya mau apa. Terus sepakati deh. Mudah-mudahan itu bisa menjawab. Terima kasih.
Terima kasih Dr. Fuadi, sangat membantu ya. Jadi nanti silakan pilih mentornya dan menjadi mente yang baik. Ya, silakan ada pertanyaan lagi dari ya. Silakan Dr. Tesha ya. Ya. Tesha is my pediatric resident.
Terima kasih Bu. Ada dua pertanyaan, satu untuk Dr. Tom, satu untuk Dr. Ahmad Fuadi. First, I want to ask you, Dr. Tom. I am Tessa I am a pediatric resident of M. Jamil Hospital. You have said in your presentation, TB is associated with persistent depression. I want to know, how about in Liverpool? Is the psychiater taking a part in this case, especially in teenagers? Or just making a class of TB, like you said before, to decrease the stigma of TB in environment. Ya, yang kedua untuk Dr. Ahmad Fuadi, Dok.
Okay, thank you very much for the question. So I think stigma towards people with TB and self-stigma amongst people with TB is prevalent wherever you go. I don't think it really matters where the person with TB is. I think that it does vary in terms of the extent and the depth and the proportion of people with TB who experience that stigma. I would say in the UK where I work, the stigma is mainly, I think it's quite closely related to isolation, actually. So when somebody is admitted to hospital, often they're kept in hospital behind 2 closed doors. Everyone wears a mask when they go in, like COVID, they wear a mask as well. And we look after people with drug resistant or extensively drug resistant TB. And for me, in a high income, low TB burden settings, it's the people who stay in hospital with drug resistant TB for months on end, who lose their social network, who become institutionalized over that time, who have very little contact with the outside world, who I think suffer really mentally. And even if they're not stigmatized actively by healthcare workers, I think they feel that self-stigma strongly because they're not allowed to leave. I mean, legally, until they've had 2 negative sputum tests, if they've got drug-resistant TB, and they have to have 2 negative cultures, so it takes weeks for them to legally be let out of hospital. I think, I don't know in terms of the duration of stigma amongst people. Again, like I said before, I do think that if people can return to their level of what they feel is their value to their community, their value to their household, their value to their country, if they look the same as they looked before they had TB, they put back on weight, they're not coughing all the time. I think that a lot of the time, those are the things that will then make them feel almost like they can forget about tuberculosis. So I do feel that, getting back to normal life is probably the key thing. But for some people, they never regain that normal life. They never get back the work or the job they had before. For some people, we talked about in the Puskesmas, they lose their families. They get, women especially, are divorced or thrown out of their household because of tuberculosis. So for some people, I think that stigma will be there forever. But I think for the majority of people, once they are back to their normal functioning, normal weight, they look normal, their symptoms have gone, I think that stigma will reduce. I hope that's.
Untuk yang kedua, Dok, pada Dr. Ahmad Fuadi, untuk thank you Dr. Tom for your answer. Untuk Dr. Ahmad Fuadi, untuk memulai penelitian nih, Dok. Misalnya kita mau meneliti suatu hal, kan kita berharap di hipotesis jawabannya iya ya, Dok ya. Kalau misalnya nanti setelah kita lakukan penelitian hasilnya ternyata jauh dari yang diharapkan, misalnya negatif gitu. Apakah ini cukup layak juga nggak, Dok, untuk dipublikasikan? Kan bisa jadi kita membantah satu teori gitu, bukan berarti hasilnya itu sesuai dengan harapan kita. Nah, seperti itu, Dok. Makasih, Dok.
Oke, terima kasih. Ini selalu jadi hal yang saya sering marahin residen sama mahasiswa. Karena yang dicari selama ini adalah, Dok, nilai P-nya nggak kurang dari 0,05, gimana ya? Gitu. Karena mereka berpikir bahwa setiap kali penelitian itu harus sesuai sama hipotesisnya. Padahal filosofi dari penelitian adalah kita berusaha untuk membuktikan apakah hipotesis kita benar atau salah. Bukan membuktikan hipotesis kita benar. Tapi ada kelanjutannya, benar atau salah. Terus gimana kalau saya kok nggak sesuai ini, Dok, sama hipotesisnya, beda sama hasil-hasil yang lain. tidak apa-apa sama sekali. Selama metodologinya, jadi you have to invest more in the methods when you plan your study. Jadi harus invest agak lama di metodologi. Saya biasanya termasuk pembimbing yang susah kali ngasih approve buat maju proposal. Kalau sama penguji yang lain kayaknya gampang, sama Dokter Fuadi susah banget katanya. Cuma buat saya adalah kamu harus benar-benar dulu maksudnya apa sih, mau ngerjain apa. Clear dulu. Kalau mau ngerjain itu gimana caranya, metodologinya gimana. Kenapa? Supaya pada saat nanti dianalisis datanya tahu. Kalaupun tidak sesuai dengan hipotesis, Anda ngerti kenapa kok nggak sesuai sama hipotesisnya. Gitu. Jadi sama sekali tidak masalah ketika kita dapat, dan kemudian justru itu menjadi pengetahuan yang baru. Karena nggak seluruhnya apa yang ditampilkan. Ini namanya adalah publication bias. Selama ini yang dipublish itu kemungkinan besar adalah yang positif. Yang negatif-negatif enggak dipublish. Padahal kita juga butuh itu sebagai sebuah pembelajaran dalam kehidupan kita. It is about knowledge. It is not about the positive result. You just publish when once it's positive, yeah, the hypothesis is correct. But when your hypothesis is not true, yeah, it's not statistically significant, for example, it is also worth, because we talk about knowledge. The thing is, you have to explain why it doesn't happen. It didn't happen in your study. Apa yang membuat ini tampilannya jadi berbeda? Saya juga sering marah kalau sama mahasiswa datang kemudian bikin diskusi. Diskusinya tahu nggak biasanya apa? Studi ini sesuai dengan hasilnya sesuai dengan studi A. Studi dengan studi B sesuai dengan studi C, selesai. Hasil ini tidak sesuai dengan studi C, tidak sesuai dengan studi D, selesai. Saya tanya, kenapa nggak sesuai? Ada nggak masalahnya? Kenapa? Karena yang kita bangun pada saat kita melakukan studi adalah critical thinking. Kalau saya ketemu A, kenapa? Kalau saya ketemunya bukan A, kenapa? Jangan takut sama penguji, takut hanya sama Allah. Maksudnya jangan takut sama penguji. Nanti kalau hasilnya begini nanti ditanyain sama penguji. Enggak. Tapi ketika hasilnya negatif, kenapa ya? Kok bisa ya? Oh, kemarin karena saya pakai toolsnya nggak benar, karena nggak sesuai sama panduan, karena populasinya beda sama populasi itu, karena ini memang tidak sensitif untuk usia segini. Itu semua harus dieksplorasi. Dan saya beberapa kali juga publish yang tidak sesuai dengan hipotesis. Jadi jangan khawatir. Kalau tidak sesuai dengan hipotesis, selama kita mampu mendiskusikannya dengan proper dan kuat, kenapa itu bisa terjadi? Selalu ada potensi untuk dipublish. Jangan takut. Ya, terima kasih.
Okay, maybe we have one question. Okay. Okay, Pak. Silakan. Ada mic, tolong.
Sebelumnya, terima kasih dan selamat sore. Nama saya Ivo da Costa Soares. Kami dari mahasiswa S3 dengan teman kami di sini. Kami 6 orang dari FKM. Tapi kami hanya untuk memberi suatu suggestion untuk kami mahasiswa asing. Sepertinya kami mengharapkan sekali dari dokter untuk meng-guide kami tentang menulis ke Sinta 1, 2, bahkan ke level yang lebih tinggi. Itu harapan kami. kami jauh dari Timor Leste, mengharapkan sesuatu dari Universitas Andalas. Jika kami balik, kami sudah bisa menulis sesuatu yang baik atas nama Universitas Andalas. Hanya itu saja yang kami mengharapkan. Ini satu. Dua, kami dapat kursus bahasa Indonesia setiap hari Senin sampai hari Jumat. Seperti saya, dulunya kita sama-sama, saya sekolah dari SD sampai perguruan tinggi saya pakai bahasa Indonesia. Tapi kita mengharapkan sekali ada pelatihan seperti dokter Pak Ahmad tadi mengatakan bahwa guide-lah kami, jadikanlah kami penulis yang baik. Jika kami balik ke Timor Leste, menulis sesuatu yang baik atas nama Universitas Andalas yang kami banggakan dan kami cintai. Terima kasih.
Ini yang mesti jawab dari teman-teman di Andalas. Tapi mudah-mudahan mudah-mudahan dari Andalas nanti mendapat guidance. Kalau Bapak berharap saya senang kalau ada banyak orang yang approach kemudian minta minta bimbingan. Terutama mahasiswa-mahasiswa, kadang-kadang bukan mahasiswa dari universitas saya sendiri. Ada dari universitas yang lain ngelihat terus kemudian dia bilang saya mau di-guide. Selama kita bisa duduk dan kemudian kita mau ngapain, sama-sama bikin target, yuk kerjain, pasti insya Allah bisa. Gitu. Dan itu juga yang diharapkan dari mahasiswa doktor, mahasiswa master, ya. Lalu ketika kita approach seseorang, kemudian kita juga punya clear objective. Saya mau apa? Kalau biasanya ada dua tipe. Yang pertama cuma bilang saya mau nulis. Terus saya tanya nulis apa? Enggak tahu dok, tapi saya pengen kayak teman saya. Loh, kalau kamu sudah punya clear objektif mau nulis apa, targetnya apa, oke kita duduk bareng. Tapi kalau kamu sendiri tidak tahu apa-apa, biasanya saya bilang suruh cari dulu maunya apa, gitu. Karena itu bantu. Yang di sini, yang di Academic University, mereka juga sibuk banyak kerjaannya, koreksi soal, koreksi jawaban mahasiswa, ngurusin modul, harus riset juga, kadang-kadang harus cari duit juga. Ya, jadi juga respect terhadap mereka, bagaimana cara respect terhadap calon kolaborator, kita datang dengan sesuatu yang kita sendiri sudah tahu maunya apa. Gitu. Perkara itu belum matang, nggak masalah, tinggal nanti dimatengin bersama-sama. Mudah-mudahan menjawab, Pak.
Ya, baik Pak, nanti mungkin yang diharapkan Bapak tadi akan setelah mengikuti program akan bisa ketemu ya. Jadi bisa nanti sambil berjalan latihan menulis, latihan membuat proposal, dan latihan membuat publikasi sederhana ya Pak. Ya, nanti kapan-kapan kebetulan kita juga di tim S2, S3 Kesmas nanti bisa diskusi sama-sama. Ya. Mungkin satu tadi lagi ada, ya Dokter Yulia silahkan. Yang terakhir ya.
Thank you, ma'am. My name is Helsa. I'm pediatric resident. I would like to ask a question. Two questions. The first question for Mr. Ahmad. You said that failure is part of success. When someone fail, how to bring their self back, like from mind, soul, and spirit? The second question is, can you, both of you, Mr. Ahmad and Mr. Tom, to give us tips and tricks how to make a good collaboration, even both of you from different place. I mean, like Mr. Tom from Liverpool and Mr. Ahmad, like from your education history from Rotterdam. Thank you.
Okay, the first question: when you had a failure, and how you keep not to down. Yeah. So the first thing is a positive mind. It's a positive mind. It's like, first you have a quote, you put it in your wall, and you read every morning, every time you sit down in on your table and you see the quotes. So it gives you spirit. The second one, you have to have a supporting system of yourself. The supporting system, because some, some sometimes you can deal with it with yourself. You have to share it with others. Yeah, seek your supporting systems and share with them. You have a friends, for example. You have teachers. You have a couple. You have a suami, istri, dan segala macam yang you are comfortable with to talk, because they will um, they will give you support. And the third thing is the positive minds. I don't know. It is quite a spiritual experience, but sometimes I feel also go down, because I say that it is about 15 applications that I sent for my postdoc, and it was also a 15. And I said, it is talk to God, for example, because you you believe that every destiny is good, every destiny is the best for you. When you realize it, and then you can calm yourself. It is not about the failure. It is about the life that the God think best for you. Because like aku suka sekali lagunya Bernadia soalnya. kadang kadang ini ya, apa namanya, lagu-lagu itu sangat relate sama kehidupan kita ya, sama lagunya Tulus gitu ya, sama Bernadia itu. Kadang-kadang seringkali kita mengutuk sesuatu yang kita anggap nggak baik, tapi ada hal-hal yang baik yang datangnya belakangan kan, datangnya belakangan gitu ya. Jadi ya, husnuzon, bahasa agamanya adalah husnuzon. Itu yang pertama. Kemudian yang kedua, soal collaboration. I met Tom the first time through email, because I did my study that's already did by Tom. It is about catastrophic costs. I read a lot of his works previously, and then I was wondering about how did you divide 20%, if I remember, 20% of threshold of the catastrophic cost, and I didn't understand, and I approached Tom by email, and he's a very humble person. So and because sometimes authors didn't respond to you, but Tom's respond to me in a very quick. And he explained about this is what I did, blah 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 blah. Okay, I understand. So I did my study. So that was the first time I approached Tom, and approached with a kind heart, invited me to go to come to Sparks meeting during the UNAND conference in 2018, and after that, it is history. It is history. we have a long collaboration since then. So I'm from Rotterdam, and Tom from Liverpool, and it is not a barrier to approach anyone who are not in your institution. So I think it is the tips. Just don't dare to approach who are you think the best can answer your question. Thank you.
Yeah, so thanks, Brad. Nice words, and it makes me happy to think of our long friendship and collaboration. I would say that to follow on from what Fuad has said is you can be persistent. You don't need to be rude, but if somebody doesn't respond to your email, you can email them again and you just say, I don't know if you saw my last email. Would it be possible just to remind that person? And sometimes it's the second, third time, fourth time, and actually they answer you eventually. Obviously, there's a limit to your patience, but do be persistent because you have nothing to lose. Okay, as long as you're kind and polite, that's fine, and it's not. And if the person doesn't respond, it's nothing to do with you. It just is the person. My key messages for collaborations go back to one of the points that Fuad said is start small, right? You can start by email, get to know each other a little bit. When you get to know each other, find out what really is your passion. What do you really care about? And if you find a common thing that you both feel very strongly about, in our case, ending TB and focusing on stigma, catastrophic costs, once you've got that collective goal and you know that that person is real and they care about the same thing that you do, then anything is possible, I think, then. But when I say start small, I also mean find if there's pieces of work that either of you have got that need finishing and say, oh, I have this. Do you want to have a look at this? So I can look at yours. You start papers without any money. You don't need money initially to make collaborations. That's the other thing. People often think, I need a grant. You don't. You need time. You need to develop your relationship and you need to work together on things, share brain power, share knowledge, share experience. So yes, start small, then maybe build and say, look, there's this small grant like the Royal Society Tropical Medicine and Hygiene grants. They're 5,000 English pounds. There are many of them each year, and they're very useful grants. So you could start with something like that, and then you build and build. And during that time that you're building, you get to know each other professionally. You get to know each other personally, which is important too. And crucially, you develop trust. You have to trust each other and you have to respect each other and respect each other both for the skills that you share, but the skills that the other person has that you don't have and the skills that you have that they may not have. So you are greater than the sum of your parts, we say. You're as a pair or as a collaboration with Dr. Finney, for example, here, the team is so much stronger than any of us as individuals. So trust, respect. And for me, the final thing is, take your time. Take your time. The best collaborations I have that I value the most now, I've been working those up for years. It's not something that's happened over months. And sometimes there's been gaps and your persistence between the partners means you carry on. But I value those ones the most where we've taken slow time to really get to know each other and find our collective goal. So good luck.
And I think I should explain for myself also, because that my student now, I'm a clinician, a pediatrician, but that I also work in the community and program, because if I only stand in front of my patient, we only have one patient, and sometimes at a hopeless condition in the patient. But if we also go down to the community and the program, we can also give and sharing our knowledge to improve to the capacity of our doctor or our health worker in the puskesmas level. So that's why I always suggest my pediatric residents also to have the perspective from the community for each patient, not only about their disease. And that's why I'm here now, collaboration with Dr. Fuadi and Tom, and I also steal the knowledge and the process from Ahmad Fuadi and from Tom. So I cannot teach, I cannot do the education anymore, but I also have the small science, small knowledge from you, and I collect to reach my perspective like that. So no time, no age to learn, no time to stop learn, but you should learn from anyone around you, from anyone that have the collaboration from you. Okay, maybe the time end to our discussion, Prof. Rizanda, Dr. Os dan Dr. Dila. I think Dr. Rizanda, Prof. Rizanda, do you have any question or perspective, any comment? Okay, okay. Thank you very much to our speaker, Tom and Ahmad Fuadi. And thank you very much for our audience that have spending time to hear, and hope our sharing session can inspire you all, and maybe can have the collaboration for the future. Thank you, Dr. Ahmad Fuadi. Assalamualaikum warahmatullahi wabarakatuh.
Baik Bapak Ibu hadirin, demikianlah acara International Guest Lecture kita pada hari ini. Dan sebelum kita mengakhiri acara kita pada hari ini, disilakan kita kembali mengambil sesi foto bersama. Ya Bapak Ibu hadirin, disilakan kembali mengambil tempat di depan.
Dokter muda di sini, ayo cepat. Quickly, emergency patient. Ayo, 3 level, ya bisa, 3 level, ayo. Yes, okay. Kiri masih kosong, ayo. Dokter muda ke kiri aja, kiri masih kosong. Biar imbang, kiri kanan. Ayo, cepet ke kiri. Ya, udah cukup? Ya. Oh ya. Ya, oh enggak bisa foto, pakai itu aja. Chargernya apa? Tempat chargernya sih, chargernya. Aji ikut aja Ji, ikut aja, udah ikut aja. Ikut foto Ji ya Ji. Bobby, ayo cepat. Bobby, ya. Oke. Oke. 1, 2. Satu lagi Bobby. Ya. Aji cepat Ji. Ya. 1, 2, 3. Oke. 1, 2, 3. Satu lagi. Ya, yang online. 1, 2, 3. 1, 2, 3. Oke, tos TV ya. 1, 2, 3. Tos TV. Keras-keras dong suaranya. 1, tos TV temukan, obati sampai sembuh. 1, 2, 3. Tos TV temukan, obati sampai. Ya. Oke, terima kasih.
Baik Bapak Ibu hadirin, demikianlah acara International Guest Lecture kita pada hari ini. Dan kami mengucapkan terima kasih kepada narasumber kita atas ilmu dan wawasan yang berharga bagi kita semua. Dan kami juga mengucapkan terima kasih kepada Akademika FK UNAND, kepada seluruh tamu undangan yang telah menyukseskan acara kita hari ini. Dan akhir kata kami pamit undur diri. Semoga kita bertemu di kesempatan baik berikutnya. Wassalamualaikum warahmatullahi wabarakatuh.